Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
All right, thank you. There's a lot to get through, and I stuffed more into this than I probably will go over, but most of this is just so that you have them to peruse if you would like to on your own after this. Disclosure and our disclaimer. So I want to start with Mpox, and just as I kind of give you this up front, we're going to move quickly. So if you don't have your seatbelt on, buckle it now. Okay. So first, let's start with results from STOMP. So that was a study that I think many of you are familiar with. It was presented by two different investigators at CROI, highly anticipated. Just as a reminder, this was a randomized, blinded, placebo-controlled study conducted across 50 sites in 7 countries. And they were evaluating the use of weight-based tecovirimat for symptomatic Mpox, and the outcomes you see are listed there. The results that I'll go over here were from what they said was actually a surprise interim futility analysis that was conducted by the Drug and Safety Monitoring Board. So this is the schema of the study procedures. Patients in arm A and B were randomized to tecovirimat or placebo, while the arm C was open label for those who had severe Mpox and were at risk for progression. And then people who did progress could also transition to the open label arm if they got worse. And then samples in the physical exam were conducted at those time points that you see here. Follow-up was spanning 57 days. So these are the participant characteristics for the 344 people who were randomized and had lab-confirmed Mpox. Most of them were natal males around age 34, and a quarter of the participants enrolled remotely. So they did pivot to sort of increase the enrollment via remote means as time went on. The median number of days from symptom onset to enrollment was 8, and the median number of lesions you see was around 9, much fewer than the almost 490 lesions that they saw in Palm 007 that was conducted in the Democratic Republic of Congo. A third of people had proctitis, a third were living with HIV, and just over 20% had received a prior smallpox vaccine. So these are sort of the top line results. I think you all have probably heard by now, unfortunately, there was no difference that they saw between the tecovirimat and the placebo groups in terms of the time to clinical resolution or for the competing hazard of disease progression that required people to transition to the open label arm. And the cumulative probability of resolution by 4 weeks was almost 87%. In the open label arm, the median time to clinical resolution was about 2 weeks. And as for a comparison, in the Palm 007 trial that was done in a different context, median time to resolution was about 7 days from treatment initiation. So then they also looked at the impact of tecovirimat on other Mpox clinical outcomes, if those were different in subgroup analyses, and they did not see any statistically significant change by demographics or the type of enrollment. Many people, I think, hypothesized that earlier treatment was better, as we often see for different viral infections, and so they looked at the results if they were different by duration of symptoms, and they were not, so less than 5 days or less than 3 days from onset. Of note, the speaker, when he was sort of presenting, mentioned that the number of people who enrolled soon after symptom onset was small, so there were some challenges in enrolling people sooner than 8 days, but even so, they saw this result that was null. And they also looked at the primary outcome by other clinical factors you see there, and again, none of those were different. So just to kind of summarize, tecovirimat was safe but did not improve clinical outcomes in this U.S. population with clade 2 Mpox. That includes resolution of skin lesions, pain control, and also viral clearance from lesions. There was a slight trend towards a decrease at day 8, but still not statistically significant. And then, now there's 2 negative trials, Palm 007, and then that was clade 1 Mpox, and then STOMP. So it is really important, I guess, for us to recognize that even though we sort of seeing patients thought that this was going to be a positive trial, it's really important that we wait for clinical trials that are conducted in this way, randomized placebo-controlled trials to know. But there is still a Unity trial that's pending. We'll have results maybe in another 2 to 3 weeks, we hope. So for right now, alternative agents and combo therapy are likely what we should be using for Mpox and prioritizing people who are immunocompromised. This is just a one that you can sort of peruse on your own. I thought it was interesting. It was a poster from California DPH that just looked at all of their Mpox cases over the course of a little over a year, and they found that the reinfection rate for Mpox was about 0.14%. So it's rare, but it can occur, and we should be still considering Mpox if people have compatible symptoms, even if they have been vaccinated. Shifting gears to Doxy for STI prevention, there was a really exciting presentation by investigators from a hospital-based clinic in Milan where they looked at DoxyPEP, if it's effective, for reducing chlamydia and syphilis rates. They have already seen that in their clinical practice. And their recommendation for their clinic is similar to what CDC says, but they suggest that it should be used for quote unquote intensive use, which is having 5 or more partners. But there's a lot of concern, I think, in Europe specifically, and in the US about antimicrobial resistance. And so they wanted to look at how antibiotics are being used for bacterial STI treatment. And so this is a retrospective study of men who have sex with men in their clinic who received DoxyPEP from 2022 to 2024. And they quantified the number of days of antibiotic therapy, which they call DOT, per 1,000 person days for DoxyPEP versus people who were not using DoxyPEP. So then they compared the observed DOT for men who used DoxyPEP, which included antibiotics that they needed for treatment of confirmed STI, so not empiric treatment, only confirmed STI, against what would be expected for incident STIs in the men who were not using DoxyPEP. About 750 men were prescribed, 30% self-reported using it in the last, actually, I don't think they told us the time frame, but at least one dose during the study period. And you can see in the table, pre versus post, the incidence of bacterial STIs dropped by about 64%, and that was significant for all of the STIs. On the right, the figure actually shows, so for each STI therapy, the expected days of treatment, and the red diamond is for people who did not use DoxyPEP, and then the observed dot in the blue circle there is for DoxyPEP users. Overall, the number of antibiotic days of therapy was 7 per 1,000 person days in the DoxyPEP group. And then I think what surprised all of us who were there was that I think you can appreciate that in all of these cases, the DOT for the DoxyPEP users was actually lower overall than the non-users. So this is mostly driven by saving antibiotic days of therapy for averted chlamydia infection. So the takeaway that they sort of gave us is that despite there being existing concerns about AMR for DoxyPEP, this strategy might actually reduce overall antimicrobial use by averting incident STIs. And so this was in a clinical context, not a clinical trial. This is real world data. So I thought that was interesting and informative. And then Hyman Scott from San Francisco presented an update on their DoxyPEP effectiveness estimates. So they, just to remind you, have been doing interrupted time series of STI incidents pre-post for DoxyPEP at their sexual health clinic called Magnet in people who had at least one visit between November 2022 and September 2024. And they looked at STI incidents every quarter and tied that to basically look at, groups before and after. And the schema that you see here, that's sort of how they set up their study. Over 2,500 people using DoxyPEP in this clinic alone, median age 35, included here, mostly men. Demographics are pretty reflective of San Francisco at large. And the top line result, I think, here is that DoxyPEP was associated with an almost 4 times higher odds of incident STI compared to non-users, which shows that the people, who really needed the most were seeking it out and using it. And additionally, from the pre to post period, there was no change in the STI incidence for the non-DoxyPEP users, but they did find that DoxyPEP was associated with a sustained effectiveness for STI reduction. And in fact, interestingly, the estimates that you see here in the lower table were similar to the efficacy that they saw in clinical trials, including for gonorrhea, which has, sort of been differential in different studies. I will skip this, but I have this here just for your interest. These are sort of other interesting DoxyPEP implementation posters that I saw. I will draw your attention just to the one at the bottom here, which was the DUDE study in Vancouver, BC. They were actually looking at DoxyPrep, and they presented data on there being no significant change in the rectal microbiome for people who were using it through 48 weeks. So people who immediately started DoxyPEP versus those who were deferred 24 weeks. So more data about sort of maybe this doesn't necessarily hugely disrupt the microbiome, which is interesting. So I'll let you take a look at that later. But these are sort of my summary and conclusions for STI prevention section, because that includes PEP and PrEP. So it is being rolled out, but there's still a lot of work that we need to do to get it to people who benefit. And we learned from Milan that reduced use of antibiotics for DoxyPEP is happening in a real world kind of clinical setting. But maybe we still need to be thinking about the criteria for sort of who is most appropriate for this. I think we all agree on that. And then, there was 2 studies on DoxyPrep that found that there was little to no impact on the microbiome or emergent AMR, which is encouraging. Moving on to lenacapavir. I think this is probably the most interesting study on len that I saw. It was a phase 1 study of a once yearly formulation for PrEP. And this was a PK safety and tolerability study, and len was given as 2 5-milliliter gluteal injections. And specifically, they were comparing 2 formulations, one that had 5% ethanol and the other that had 10%. And the study included 40 healthy volunteers, aged 18 to 55, all had a BMI less than 35, and 20 of them were in each group. The results have already been published in Lancet, and the article is there if you would like to read it. The graphs on the right are sort of easier to digest, I think, and show that after the IM injection, the concentrations for both formulations surpassed protective levels quickly, and then those were actually even higher than the twice-yearly sub-Q len concentrations that they saw in Purpose 1 and 2. And they had troughs that were sustained in much the same way, sort of, and actually above the threshold out to 56 weeks, so sort of surpassed the 52-week mark that they looked at in Purpose 1 and 2. But as you might imagine, you're getting 2 5 ml injections. Injection site reactions were quite common, and they were reported actually in 80 to 85% of participants in both groups. So this included sort of pain, bruising, swelling. And for the second group, some people were even sort of walking funny because the shot hurt, and somebody felt hot and dizzy and sort of nearly passed out, they alluded to. But most of these adverse events, they say, were considered to be mild or moderate, and there were no grade 4 adverse events or lab abnormalities. And in the graphs, you can see that most participants actually reported no or mild pain that usually resolved within a week. And pre-treatment with ice, interestingly, decreased the pain ratings on days 1 and 2 in that group that got the more concentrated version. Okay, so once yearly IM len gave us good plasma concentrations beyond 12 months at levels that we know are efficacious based on the Purpose trials. It was safe, but injection site pain was common, seemed to resolve, and maybe that pretreatment with ice is good. There was a planned phase 3 study, or is a planned phase 3 study for IM len to be given once yearly. It's already planned, and they're thinking about they may even be able to use a lower dose. And so we still know that this could have a significant public health impact for ending the HIV epidemic, but it's not clear sort of how much this will be available, scalable, and how it will be priced. I think that will be key to knowing how we can use this. Last sort of big section here. So this is about CAB for prevention. So I think we all know it can be challenging to diagnose HIV in the setting of CAB-LA use. This presentation sort of underscored that with additional data from HPTN 084. So to remind everybody, that was a phase 3 double-blind safety and efficacy study for CAB-LA versus oral FTDF for PrEP in women in sub-Saharan Africa. So they had nearly 2,500 participants who attended over 24,000 visits where HIV RNA or viral load was used for screening. And there were 87 women who had at least one reactive HIV test that required adjudication by a committee. Most of those were actually determined not to be a true HIV infection, but 8 or 9% of them were confirmed as true cases. And so the flow chart here kind of shows the breakdown by PrEP agent used. So in 4 of the 8 cases, an isolated RNA was positive, and then 3 of the 4 of those were in women who had used CAB, and the RNA was below the limit of quantification, so it wasn't really helpful in distinguishing true versus false positive. And then conversely, women who used FTDF had significantly elevated viral loads that were more convincing for true infection. So there were 77 cases with at least one positive HIV test that were determined not to be true infections, and of these, 12 or 15% had a false positive HIV RNA result. Most of those women had actually used CAB in the last 6 months, and several of them had significant delays between injections. And these positive RNA results did lead to them pausing CAB at some point in, I think, all of the cases. Then they calculated the false positive rate and the positive predictive value and sensitivity of having a single HIV RNA being positive in the setting of CAB use. with the caveat that there were only the 12 cases that they included here. I think you can see the false positive rate was quite high and the positive predictive value was low. And these estimates also sort of varied by the duration of CAB use. You can see that for people who had CAB use in less than 6 months, the numbers were different than those who were greater than 6 months. The sensitivity was also low, like 63%, but again, just based on a few cases. And lastly, Rafi Landowitz talked about some more data from HPTN 083, which was very similar, CAB versus FTDF for PrEP, but conducted in men. And so he talked about viral suppression rates using a case series of 47 men who acquired HIV on CAB at any point in the study from the blinded phase through the open label extension. There was a busy table that he presented, but I tried to kind of summarize like a torrent of data that he presented very quickly. In 083, they were quite strict and they considered their viral suppression cutoff to be less than 50. And so if people had a viral load of 51, they consider them not suppressed. But I think clinically, we all think that 51 is considered suppressed, and guidelines, I think HHS guidelines support that. So I took the liberty of kind of counting those as suppressed, and I sort of redid the table here. And the takeaway is that 86% of participants suppressed on an integrase-based regimen at diagnosis compared to 85% on a different anchor regimen. Usually that was a boosted PI with 2 NRTIs. And the proportion who reached viral suppression was a little lower in the groups who were greater than 6 months out from their last CAB injection. So I'll leave this here for a second for you to just take a look. But I think it was good news to kind of see that people did well after they acquired HIV and were put on an integrase regimen. And they went back and tested historic samples, and they found that 21% of the people who had integrase mutations actually before they started ART for treatment, which is that was interesting. But even so, all of those people eventually suppressed on their first regimen, regardless of when their last CAB dose was. So I think we still need to understand kind of what the clinical significance of these resistance mutations is and how durable the viral suppression can be. And so that's from the second presentation. From the first one, I think what I took away is that a single isolated HIV RNA performs poorly. So I think she said they ran about 24,000 tests to find 4 true positive cases. So, maybe we should be kind of considering if this is cost effective as a screening test and has potential for some, negative clinical consequences. And I saw Joanne was on. She got up and made a statement for this at CROI, which I thought was great.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.